Good afternoon all. So my free paper title is Recurrent Corneal Erosion Syndrome, the role of KSOS epithelial mapping. So RCE is a condition which is characterized by abnormal epithelial adhesion to the Bowman's layer, causing spontaneous episodes of epithelial breakdown, causing the patient to have sudden onset ocular pain, photophobia, blurred vision on awakening. So it's a condition primarily diagnosed through slit lamp examination, and despite advances in understanding the pathogenesis, recurrences remain unpredictable, and the follow-ups often rely solely on clinical examination. So here, our aim is to determine the role of ASOCT epithelial mapping in delineating the areas of epithelial instabilities across the acute and quiescent phases. So materials and method, it's a prospective observational study which has got IRB approval carried out during the period of December 2022 to November 2024. And we have included all the patients with symptoms suggestive of RCEs, excluding those with corneal scars, infection, dystrophies, and surgeries. So at presentation, the patients were subjected to slit lamp examination, fluorescent staining, and ASOCT epithelial mapping. Then they were started on uniform medications, which included lubricants, sodium chloride ointment, and drops. And they were asked to follow up after 2 weeks to ensure healing of the epithelial erosion. And the following were repeated in the follow-up visit also. So this is a case in which a patient presented to us in the acute stage, that's in the primary visit. So here the slit lamp examination shows areas of epithelial erosion, and the same day ASOCT epithelial map shows red regions which are termed as hotspot, which are actually the epithelial thickening, and these hotspot are corresponding to the area of epithelial irregularity. So the same patient, when he came after 2 weeks of starting medication, we can see a healed epithelial erosion in slit lamp examination, and the ASOCT epithelial map repeated show a persisting hotspot. So coming to the result, we had a total 40 patients enrolled, out of which 19 came for the follow-up visit, the mean age of the sample being 37.5, and predominantly they were females. So when we compared the slit lamp examination, the epithelial erosion present in the primary visit were 84.2%, which has reduced to 18.75% in the follow-up visit. That is, 81.25 of the patients had their epithelial erosions healed on slit lamp examination in the follow-up visit. So when we analyze the hotspot in primary and follow-up visit, 94.7% of the patient had hotspot in the primary visit, whereas in the second visit also 73.7% had that persisting hotspot, despite most of them had their cornea clinically clear. And also we have analyzed the hotspot in terms of correspondence in size and site in first and follow-up visit, which shows 92% of the hotspot in second visit corresponded in size and location to the initial mapping finding, even though the epithelial erosion have healed. So as we mentioned, it's a primarily clinically diagnosed condition through slit lamp examination, and identifying these areas of epithelial irregularity using slit lamp examination alone is challenging in quiescent stages. And it was the work of Oikonomakis et al. That highlighted ASOCT epithelial mapping as a promising tool for detecting the areas of epithelial irregularities and potentially guiding targeted interventions. So our study strengthens this finding. That is, most of the patient had their epithelial erosion healed on slit lamp examination, but 73.6% had persisting hotspot on ASOCT epithelial map in the follow-up visit, and most of them were corresponding in size and location. And these all findings suggest that there is a persistent subclinical adhesion abnormalities despite apparent healing of the cornea. So the limitations were we had a small sample size, and the follow-up duration were shorter, and only 9 mm of the cornea was imaged in anterior segment is OCT epithelial mapping, and RCs beyond this area was difficult to map. So the highlights are it's a prospective study and the first study to demonstrate a method for identifying the areas of abnormal epithelial adherence in patients presenting without epithelial erosion. So we conclude that ASOCT epithelial mapping effectively localizes the area of abnormal epithelial adherence in recurrent corneal erosion syndrome, thus identifying the areas prone to erosion even in cases of a clinically resolved RCEs and in microform erosions. Thus, it can be a valuable adjunct to slit lamp examination in the diagnosis as well as the management. These are my references. Thank you.
trying to say that it's a hot spot, then you'll have to validate saying that this is first day healing, this third day healing, this seventh day healing. Yes or no?
Sir.
You yourself are saying that subepithelial adherence hasn't happened, epithelium is covered up. That is how epithelial turnover happens.
Yes.
We all accept it as a science. You are making it as if appear as if it's a flaw. It's not a flaw. That is how it will happen. So that we all understand. Should you have given the time frame from when the erosion happened to when the healing actually becomes permanent, that would have thrown some light. Just saying that we'll do ASOCT and pick up hotspots doesn't matter, doesn't bring us. So what do? We'll presume. The question is like vice versa. You, in a recurrent corneal erosion, patient comes to you, you do a ASOCT, patient has no complaint, patient's slit lamp is perfectly normal, staining is 0, and you do ASOCT, you pick up 5 hotspots. What do?
Like if the patient is symptomatic, still
No
that
symptoms.
no symptoms.
You yourself said no symptoms. What do?
So we can actually call them back. If they are symptoms only, we had to start them on any medication. So we can ask them to follow up after a duration of 2 weeks at least. That if there is any.
This decision, a general ophthalmologist himself will make. No. Why should you have an ASOCT and a corneal surgeon looking at that and telling the same? Whatever you said now, a general ophthalmologist will say. You understand?
Yes, sir.
So the weight of an investigation is in the validation of the result and the eventual output from that which translates as interference or intervention in that particular case. Here it doesn't come. It doesn't come. If you had said, like, if there is hot spots, then you'll have to increase lubricants, you have to increase something of that kind, then I would have taken it. There is nothing what you are trying to say. You're just trying to say that incidentally hot spots are revealed. I am saying that they will be revealed. 100% they will be revealed. Okay.
Okay, sir.
So there is no correlation here. So that's why I said when you are designing a study, that question, that initial question should be strong, or else the inferences will come, but they'll not be valid.
Okay, sir.
These persistent hotspots patients had any history of diabetes and all? Did you
Systemic.
find out? Because you
No.
told now hotspot is still there.
Yes, sir.
Why don't you put them for this? Just investigation for in academic interest.
We'll try to do it,
Because
sir.
diabetic patients are notorious for having recurrent erosions.
Okay.
So naturally, if you see the hotspots and all, why can't you put them for blood sugar and all at least? Or at least history of diabetes was there in those patients.
We haven't looked into any systemic correlation, sir. But any ocular infections or anything they had, we have excluded them. But systemic correlation, we haven't done yet. Anything. We haven't analyzed.
Okay.
Thank you, Doc. Thank you, Doc.